Hello, everyone, and welcome to our session today designed to support you in lowering healthcare costs by focusing on some of the key takeaways found in national employer health data. Each year, KFF, the leading health policy organization in the US, releases its employer health benefit survey, which is really considered the gold standard for understanding national trends in health benefit design. Today, we'll explore what those 2025 results reveal and how you can turn that information into strategies that manage cost, improve value, and bend the trend in 2026. Admittedly, diving into this topic feels a bit like checking my Spotify Wrapped, the end of the year recap of all of the songs I've listened to throughout the year. This webinar may parallel that a little bit. You'll see what's been popular, what's changed, and might even find a few things that surprise you. My name is Melanie Shinneman. I'm the Vice President of Business Growth and Member Strategy at the Alliance, where we partner with employers to self-fund smart. While I may be new to the Alliance, I'm not new to the healthcare industry and the very real need for employers to lower costs for their businesses and their employees. So I'm so excited to be hosting today's program. Our goal at the end of today's session is for you to be able to see how your plan compares to other organizations, identify emerging trends, and ultimately turn the insights that you gained into strategies that lower cost, improve value, and set the stage for what's next in your benefit design. Before we get started, I want to let you know we'll be using live polls throughout our session today, so you can benchmark real time alongside with your peers that joined in. Your participation does matter. It'll make a difference, so please jump in when you see those on your screen. Please don't be shy about posting in the chat. We welcome helpful ideas, questions, discussions, and we've reserved time specifically for Q&A at the end of the session. We'll answer as many questions as we can at that time. Additional resources are available by clicking on the resources box on your screen. A recorded video of the event will also be available on the events page of our website and our YouTube channel. And we plan to email all participants today a link when it's available next week. At the bottom of your screen, you'll have additional resources that are available by clicking within that box. Finally, I want to take a moment to thank our 4 slides for today's session: Delta Dental, National Cooperative RX, MH Imaging, and our newest sponsor, Checkups by Pathfinder Health, who offers virtual health screenings for employees. To learn more about how each of those partners can help you on your self-funded plan, there are links available in the sponsors box on your screen. Not only do we appreciate their support so we can continue to do programs like this, for our employers and our partners, our sponsors really are alongside us as we're trying to push our industry forward and manage spend for all of us on this call. Now, let's dive in and take a look at what the national data is telling us. This session is broken apart into 2 parts. First, we'll lay the foundation with an overview of the survey results and a panel discussion. And as I mentioned earlier, we'll leave room for your questions at the end, so please jot them down as they come to you. To get us started, please join me in welcoming Matthew Ray and Dr. Lynn Cotter. Matt is the Associate Director of the Program on the Healthcare Marketplace at KFF. He's going to walk us through the highlights of this year's Employer Benefit Survey, which is something he's managed since 2011. So great to have the 15 years history with him on this call. He's also co-authored numerous reports on employer-sponsored health insurance, healthcare costs, coverage trends, and all of which help us understand how private insurance markets function and have evolved over time. Dr. Lynn Cotter is a Senior Health Policy Research Manager for the Program on the Affordable Care Act and works on the KFF Health System Tracker, which monitors healthcare costs over time. Prior to her role at KFF, she worked as a research assistant at Wisconsin DHS, or Department of Health Services. In that role, she analyzed healthcare trends and created innovative ways to improve health communication, which was critical for allowing for more data-informed policy changes. Welcome, Matt and Lynn. We're grateful to have you both joining us today to dive into the trends, and I'm so grateful to hear your perspectives on how that will shape employer decisions moving into next year.
Thank you to the Alliance, and thank you so much for having us. We are really excited to do this work every year and really excited to share it with you. So KFF is a nonprofit, nonpartisan research organization where we try to put out as much information as we can on the healthcare system and how it's working and how much things cost, in the hopes that it informs employers about their decision making and improves the policy making we see both in the state and in the country at large. So this is one of our benchmark products. We've been doing it for 27 years, the Employer Health Benefit Survey. Basically, what we try to do is talk to as many employers as we possibly can about health, their benefits, and ask them extraordinarily detailed questions about up to two of their plans, but many of their strategies and thinking about their employer benefits. Many employers use this survey for benchmarking their plans and thinking about how it tracks up with other employers across the country. If you filled out the Employer Health Benefit Survey in the past, or you are invited to do so this year, we encourage you to do so. We're able to do this survey and put this information out for absolute free and no cost to anyone, because employers fill the survey. So we're always really grateful to the employers who take the time to do it. And this is a big project every year. We put out hundreds of graphs. I think this year I made 250 graphs based upon the survey. So we're only going to touch on a small segment of what's in the survey. And if there are other things you're interested in, happy to talk to you about it in the question and answer, but also there may be more information in the report online, which we encourage you to look at. This year we did a sort of add-on to the employer survey in which we did focus groups with employers. Lynn, do you want to tell us a little bit about what that was and why we did it?
Yeah, absolutely. So thank you again to the Alliance for having us. We're very excited to be here, and it's sort of back here because we conducted 6 focus groups across the country, including one with members, employee members of the Alliance. And so we're really grateful to have had the opportunity to speak with some of you. I see some of you on the call. It's really nice to see you again. So we spoke with over 100 employers, as well as brokers and consultants about healthcare trends. And I'll be sharing some of those results with you here. And some of those reports are on our website as well. And some are still forthcoming. So I'm looking forward to talking more about that.
All right, let's jump in. Okay, newsflash to no one. Health insurance is very, very expensive. So on average, to insure a family of 4 in the United States is $27,000, which is the sort of the green bar. So you can see in this sort of 27 years we've been doing the survey, health insurance has quadrupled, essentially. The blue bar is the cost for single coverage, which hit $9,325 on average. Incredible amounts of variation here. I mean, premiums vary for a bunch of reasons, sort of the age of the workforce, the cost of the providers included in the network. We have many employers who have plans that are much more or much less, but that is the national average for this year, for 2025. So flipping to the next slide. So how has health insurance been growing? It's a great question. So this year we saw 6% growth in health insurance premiums, which I think feels like a lot of money to many employers. That's about $1,400 increase in the average premium from 2024 to 2025. So 6% is clearly a lot of money, $1,400 per family enrolled, especially when it's 6% off of a huge number. Now, how have premiums been growing sort of historically? It's kind of interesting. So we had this sort of period kind of up until the pandemic where we had sort of relatively modest growth, I would say. We mostly saw around 4 percentage points of premium growth. And then the health system and employer benefits were in a lot of flux during the COVID years. And we saw relatively low premium growth, especially as utilization fell during the pandemic, and then a rebound afterwards, complementing with higher inflation, higher wages being paid in the healthcare sector. So now that we're kind of moving out of the pandemic era and into whatever is next, the 6% I think is sort of larger than what we've seen in the recent past, obviously more modest than longer term trends. The interesting thing about the 6% is that it comes with sort of lower inflation overall. So we saw inflation of 2.7% in the past year. So now family premiums are once again sort of outpacing inflation. Now, going into 2026, there's lots to think about cost. I mean, early reports are definitely suggesting that we're going to have many employers have higher than expected utilization in 2025, and that will have bearing on 2026 premiums. So we're looking at about medical cost growth rate about 9%. That's not a number we put out, but that's what sort of the consensus is amongst sort of the actuaries and consulting companies who make projections going forward. There's probably higher growth in the small group market. So looking at 2026, I mean, the early predictions are higher premiums. I'd love to get your guys' sense on what you're seeing in your renewal. So everybody take a minute here, and I hope it's clear on how to do this. There should be an online poll, and then we will all select an answer, and we'll see where we're at. So the medical trend is 5, and that would be option B, but I think some of you may be experiencing higher or lower premium increases.
First chance for everyone to jump in and participate real time.
The interesting thing I'll say, when just to give people a chance to do it, the kind of interesting thing, one of the interesting things about where we are in terms of the healthcare cost discussion is over a 5-year period, we are now, premiums have grown at this roughly the same rate as inflation over 5 years, which is sort of remarkable, given we had so many years in which premiums were growing much, much faster than inflation. So where we are in 2025 with premiums being higher than inflation, the question is, are we going back into an area in which premiums are going to consistently go faster than inflation? Or are we going to continue this era? This was the aberration, and we're going to go back to an era in which costs are growing kind of on par with prices in the economy in general. Maybe got 51% responding. At what point do you want to call it?
We can go forward. Thanks to those that jumped in so far. You can go ahead.
So what do you think, Melanie? Does it surprise you? We're seeing kind of a dispersion of premium increases. 36%, the biggest number, among the 10 to 15% change. Is that kind of what you expected?
Unfortunately, I'm surprised to see the 22% under 5. We really have hit between that low single digit or high single digits, low double digit number. That's been mostly what I'm hearing. So that part sounds spot on. But I'm excited to see that many falling in the low end of that range.
Yeah, I mean, the number that really jumps out to me here is actually how many employers are hitting that over 20%. I mean, I think that is not atypical right now in the small group market for self-funded employers who have more ability to work on their cost and aren't in the regulated small group market. That is a big increase, and I think that is a hard thing to budget for. So that is interesting. I mean, I would be obviously curious to know for those large employers that are facing huge costs, what are the cost drivers for them? I mean, obviously, I think new specialty drugs are one of the reasons for small, mid-size or smallish self-funded employers who get hit with huge increases like that, especially when you're so far out the medical trend. Do you have a take on that?
Yeah, that makes sense. That's what I'm hearing as well. Some of the treatments, the new treatments that are coming out, the cost of them is increasing higher than expected. So between new treatments and the number or disease severity over the last several years, we've seen both cancer treatment, but also other diseases being diagnosed at later stages where this severity and treatment ends up being more expensive. And as we're talking about affordability, if people are deferring care, then it doesn't negate the cost, it delays the cost and potentially increases it, or we're seeing the kind of the pent-up demand.
You can tell that 2 people give thumbs up and 2 people have the horrified face. So I think that the people with the thumbs up are probably the people with the 5% increase in premiums. So we'll be back next year, hopefully, if the Alliance will have us to, and we'll see what we got from the national average. So, I mean, this is kind of what we were just talking about, Melanie. This is looking at this year. We asked employers what were sort of the cost drivers they saw as driving premiums. So, just as a recap, we had 2 years of 7% growth prior to this. I mean, I was sort of expecting to see hospital services here, which obviously are a big part of what drive health insurance premiums because hospitals are where so many services are. We've seen so much consolidation in the hospital markets in so many parts of the country. We've seen sort of slowly increasing prices. But the thing that jumped out was employers were really focused on prescription drug prices. I mean, I think part of that is probably GLP-1s got hit this year. GLP drugs only make up about 15% of employer spend on average, but that was the thing that employers were focused on. I have a couple thoughts why, but Melanie, does that kind of make sense with what you expect from employer members?
It does. I'm hearing a lot about the concern about prescription costs. I'll share an example from a poll that I took of some of those on a former team. My largest drug that I ever had on an account as an account manager was $360,000 years ago. And I had done a poll of those in my circle and just asked what they were seeing. And the average drug was between $800,000, $1 million, 1.5. I had someone mention a $3 million drug on an account that they were managing. And that really does skew how much of the premium is going towards that segment in particular. It's really hard to manage.
It's really hard to predict for it when you don't know when you're going to be hit with a huge drug claim.
Absolutely, when it's one drug causing that much of an increase.
So cell and gene therapies are definitely a driver going forward. I mean, the other thing that's happening with drugs is that we've had several years in the last decade where we've had spikes in drug spending. I mean, obviously in 2014 with the Hep C treatments, I think in recent years, employers are very focused on GLP-1s. The other thing on this chart, which is kind of interesting, is that higher utilization of health services is not particularly high. I mean, that is what many insurers are pointing to as a driver of health cost in 2025, especially in other markets. And I mean, that would be the place you'd be concerned about premiums increasing because of some sort of pandemic rebound, which to the extent that is still happening, I think is up for debate.
Makes sense.
All right. So obviously workers, the premium is very expensive and workers and employers both have to pay the cost. I mean, so this chart is the green is what the average worker contribution is, and the blue is the average employer contribution. So on average, employers toss in about $20K for a family of 4, and workers toss in $6,850. Obviously, if you want to benchmark your plan, we have an interactive graphic on the website where you can punch in where your firm is located and your industry and how big you are, and it'll give you all these numbers so you kind of look more specifically. I know the Alliance also does a lot of that stuff for employer members as well on benchmarking contributions. I mean, so I have a couple thoughts on this. I mean, I have lots of thoughts on this, but I'll give a couple. One of them is the share that is paid for by the employer and the employee has remained relatively consistent over time. We've been doing this for almost 3 decades, and that share is 27% this year, or 26%, basically that. Workers toss in 26% of the premium, and the employers the rest. That's stayed the same. So premiums have gone up, and workers and employers have sort of shared that cost together. Now, going into years of higher premium growth, if how that changes will depend on a lot of factors. To the extent employers can feel like they can weather the higher cost, is definitely another question, especially if there is sort of a softening in the job market. The other thing about the green bar is just a tremendous amount of variation. I think there's lots of places in which we worry about affordability for employer-sponsored health insurance. One of them is the premium contribution, especially for lower wage workers, or workers at smaller firms who are enrolling family members. So we have lots of employers tell us that small firms that they require more than a $12,000 contribution to enroll dependents onto the plan. Which is obviously an astronomical amount of money at small firms. So this is something I continue to think about, is the affordability of coverage. Melanie, anything you want to add there?
Nope, I think that's great.
Great. All right. So, this is your question. I'll let you handle it. Take it.
Sure. As we dive into strategies for managing costs and looking at the national data in the next few slides, wanted to get your take. How would you describe the medical plan mix that you're offering to your employees? high deductible plan only? Do you do steering and tiering? Do you offer both options? Or are you trying something else? Give you a few seconds to join in on this second one. We do have quite a big audience joining us today, so really comparing real time and understanding the audience as we move forward is helpful. So we very much appreciate your participation. From the Alliance perspective, we're really seeing a mix of these where steering and tiering, more and more employers are looking at options to take it to the next step. I would say that the transition phase, we do have many employers offering both. So let's see, we have about 45 in. Thanks so much. Let's see. No notable outliers. Feel free to put in the chat if any of that feedback surprises you. I think half offering both of those options is great. Like I said, we have more employers looking at that tiering and steering, and having 18% on this call is great. Those that are looking to do what's next. So I think that makes sense for the audience that we have on today. Anything from you, Matt?
I mean, I have lots to say about this. I think we haven't, some of it was coming in a slide just a little bit, so I'll hold my thoughts and roll back to these results.
That's fair. We can keep it going. Thanks to those of you that jumped in for poll number 2.
Okay, I mean, this kind of gets at what we were just talking about around, so obviously workers pay to enroll in the plan, and then the workers are paying cost sharing. So, I mean, put those two things together, and that's where the cost is. So one of the things that is sort of nationally that has changed fundamentally about employer-sponsored health insurance is the deductibles. So we have this period from, I don't know, 2006 to 2020, let's say, where deductibles just took off like faster than anything. So deductibles were going much, much faster than premiums or workers' wages. And I think that raised all these affordability issues for people who don't have a lot of assets. So even amongst people who have jobs, many don't have the liquid assets. So what's the money in your bank accounts and checking accounts and savings accounts to meet the typical cost sharing in some employer plans now. So on average in 2025, the average deductible is $1,900. Over the last, which is the purple bar, over the last 5 years, we've had sort of more modest growth in deductibles, which I think is, I mean, that's interesting for a couple of reasons. One is I think many employers are focused on the fact that their plans are, they spend all this money, we just saw it, $20,000 a year, and they want to make their benefits usable. So if you start having cost sharing so high, it begins to raise questions over what's the point of doing this? And you want to make your benefits like benefits, and if they feel unaffordable, why are you doing it? The other thing is, but what is true is at this point, most employer coverage nationally is dominated by the deductible. The deductible is sort of half of cost sharing on plans on average, the amount of money that people spend out of pocket when they actually use services. So it requires a sort of upfront cost, which is just changes the way we use our plans. I know there's much discussion now about plans and alternatives that will reduce deductibles, increase affordability, and provide other incentives to reduce cost, such as going to lower cost providers. So the blue bar that's sort of floating up there, that's the deductible at small firms, which is obviously much, much more. So what is that? The $2,600 on average. Some covered workers at small firms are facing deductibles even higher than that. Obviously, for those enrolled in family coverage, you oftentimes have even deductibles, have to meet a deductible for multiple family members, which can really be a tremendous amount of money. So, I mean, this is what I was just saying. I wrote this slide. This is we had just asked employers what they were most concerned about, or what they thought their employees were most concerned about. I wrote this question because I wanted to talk about prior authorization, and that was one of the issues that I think a lot of the health policy world was very focused on. Is should we do things to reduce prior authorization, even if that had an impact on plan cost? And employers did not really focus on that. I mean, very few employers said that their employees had a high level of concern with either claims denials or prior auth. The thing that they really focused on was the affordability, which is literally what I was just saying, is I think that many employers are now thinking about ways to try to encourage the affordability of the cost sharing, especially for low-wage workers. Many of them have to spend a tremendous amount of their take-home pay on cost sharing, if they have to use services. And it raises a lot of concern over the health of the affordability and how healthcare prices are sort of working its way through. Melanie, are you seeing anything from employer members on affordability or what they're thinking about affordability? Does this surprise you?
The top two are our number one concerns. Our employers want it to be a benefit for their staff, and so affording both the deductible and premium, and making sure that they can use the benefit. So I mentioned earlier, so that they can actually get treatment and take care of their health. So those are the key things. We're pretty fortunate that denials in care are not a main method for controlling costs. I think there may be some larger plans where that's a cost containment mechanism, and fortunately, we're not seeing that.
Yeah, I think there's probably more discussion nationally. I mean, obviously, in the Medicare Advantage market, prior authorization is obviously a big part of how insurers control cost. I mean, I think that removing prior authorization, while it may reduce the administrative burden of using your plans, it has a trade-off in cost that
absolutely
we have to think about. All right, Lynn, why don't you jump in? Do you want me to give the slide, or do you give the result and then your focus group findings? This is one of the things that we did in our focus groups. Employers wanted to talk about GLP-1s. There was no problem filling an hour or 2 hour focus group if you brought up GLP-1s and what employers were doing to do cost. And we actually had kind of an interesting finding here. Lynn, why don't you tell us about it?
Yeah, absolutely. So, so in the employer benefits survey, we asked what % of plans cover GLP-1 agonists specifically for weight loss. So in general, employers cover GLP-1s for diabetes, but for weight loss, it's a bit more mixed. So we see that there wasn't a big change. If you look down at the very bottom of this chart, there wasn't a big change overall in coverage. It went from 18 to 19% of firms offering GLP-1 agonists for weight loss. But among those largest firms, those firms of 5,000 or more, 43% are now covering it. And we talked to employers about these GLP-1s as well. From the survey findings, we see that there was that firms fairly overwhelmingly say that GLP-1 coverage for weight loss, again specifically, has had a significant or a moderate impact on the overall prescription drug spending. So why cover them then? I guess we did hear from a lot of employers that they consider it a significant benefit that they want to be providing for their employees. So providing the opportunity to get GLP-1s for weight loss can have a significant impact on prescription drugs, but it's also important for employee satisfaction, for example. So the firms that we spoke to are handling these large costs in a couple of different ways. The first is that they are reducing coverage. So they're making it more difficult to access for weight loss by putting, say, new limits on BMI that the employees have to reach, or the beneficiaries have to reach before they can access it. The other is that they're using sort of step-up plans or mandating that employees use some sort of online companion service or caseworker or weight in addition to the GLP-1s. So they also get some sort of case management to help support them. And then they check in to make sure that they are losing weight as expected. But the last thing that employers are doing is that they're canceling the benefit altogether. So we, in the EHBS survey, we didn't really see a decrease in the percent of firms that are offering GLP-1s for weight loss. But when speaking to employers, they did mention that that was something that they might be doing. So those results might show up next year. We're not really sure. I think in general, there's a lot of flux with GLP-1s. Particularly, there have been some announcement from the administration in recent days about the cost of GLP-1 drugs, and so we're still sort of waiting to see what's going to happen with there. We do have a poll question. We're interested in finding out what changes your organizations have made related to weight loss coverage options. And
for 2026, yeah. So I think what we saw was an uptick in 2025, and then we're expecting a decrease in 2026. you bring up the issue of price, which I think is super interesting. I'm just going to talk while people are filling out the survey. I mean, so we see these drugs came on the market at astronomical prices with tens of millions of people on employer-sponsored coverage. 44 million people on employer-sponsored coverage have a BMI, which is high enough to indicate them for these GLP-1s. I mean, the price is obviously going down in the direct-to-consumer market, and then the Trump announcement for people on for some eligible populations of people with Medicare coverage. How does that calculus change for the price for employers who may or may not be paying more than those direct-to-consumer prices? And how did we get anything on the focus groups on how employers were thinking about the price of GLP-1s?
Yeah, I mean, I think that in general they're expecting the price to change for sure. Some of them mentioned trying to send their employees off plan to go get the prescription drugs. I mean, if it's cheaper to get it from the website, then maybe that's what they're interested in looking at. But I think in general, the employers were just really cognizant of needing to think about how GLP-1s are going to increase in demand because there are a whole bunch of potentially new on-label and off-label reasons for using GLP-1s that we've seen. And so that is also of interest, certainly.
That's a good point. That's an excellent point, Lynn. It's just these new conditions are also being indicated, so it's going to be even more people who are eligible. So even if the price goes down, there's still be more people eligible, which could be a cost, more of a cost driver. I mean, not that employers don't worry.
Are there others who want to weigh in on the poll?
So that's interesting. We got about a 50% response rate on the first two polls, and we're getting much lower here. So either we wrote a tough question, or or this is such a complicated area. It's harder to think out what employers are doing.
All right. Well, let's go ahead and look at our results. It looks like
so this is exactly what we got.
Yeah.
This is exactly what we got in the focus groups. Exactly the point you just made, Lynn.
Yeah. Not a lot of expanding coverage for 2026, so specifically none. A couple of people who've dropped coverage, although some have included GLP-1s, I see, and then also adding some cost sharing, some step therapy.
Very
Melanie,
fair point, Kim, in the chat that there wasn't an option for still not covering. I think that's a very fair point. Very fair point. For those that are, we talked through, there's first the question of do you want to and can you afford to do it? And then how do you make it predictable? And all of the different access points and the variation in cost. For even those that want to cover it, it makes it so hard to do it in a way that's that they can plan for. All right, we can go ahead and move on to the next. Thanks for mentioning that, Kim. That was a really good call out.
Melanie, is there anything else you're seeing from any Alliance members on how they're handling sort of GLP-1s as a special category?
We also have a smaller percentage that is offering it for weight loss and really just setting up the criteria. So step therapy or having the rules around how they cover it is what we're hearing. But again, a lower percentage, we're seeing a lower percentage of employers that are covering it still.
I mean, kind of interesting case is the GLP-1 coverage for diabetes and whether you need to change your utilization management strategies if you're not covering it for weight loss. So I've heard from some employers is that they're seeing much, astronomical spending on GLP-1s, even though they don't cover for weight loss, because they think that more people are getting a diabetes diagnosis. Are you seeing employers with that sort of address those sorts of issues or think about those sorts of issues?
Yes. Which diagnosis comes first as the primary versus secondary? That is a consideration in the discussions for coverage. And again, how it's covered. The price points can just vary so much.
Yeah. All right, moving on to my favorite topics here is about provider networks, which is what I like to spend my time thinking about. We asked employers if they thought we always try to take the temperature on how broad employers think their networks are. And I was reassured by this. The vast majority of employers think they have enough primary care physicians to provide timely access, which is, I think there is legitimate concern about primary care shortages in many parts of the country. So the fact that we got such a robust finding here, I think, was reassuring to me, even more so than specialists. I mean, I think, so again, this is another one of those cases in which we're quantifying something that I don't think is going to surprise anybody, but that mental health access remains less robust in employer plans, or less robust in all types of coverage than the demand may require. So we get 70% of employers who said that they had a sufficient number of mental health providers. It's actually lower in California, significantly lower in California. I think over the last, this was obviously I think the issue of the moment from 2021 during the pandemic and through, where many employers were trying to supplement their access to mental health care providers, adding new virtual benefits, adding new point solutions, and still we see a lot of employers who think they need more. Melanie, that true for you? What do you see in Alliance members, or does this still raise to the top of a concern for you? Is mental health access?
Absolutely. Yep, I think that's an issue across the country. Absolutely.
Oh, and this is your question. I'll let you take it.
Sure. So for another poll, thank you for playing along on your screen. For those of you using the Alliance Network, I know that we have some that are with us and not with us. How do you use your Alliance Network to influence employee choice and lower costs? So do you offer the various network options but not offer incentives? Are you exploring tiering and steering like we mentioned earlier? Are you trying to guide your employees through those incentives and more actively engage in that tiering and steering approach? Or you're not sure. You have your strategy in place, but you're not actively managing the different access points. And really, engagement has been, for the 20 years I've been in the benefit industry, engagement has been the hardest area to crack. How do you get the message to each employee when they are trying to access that specific care? We're in the middle of open enrollment season where we're talking about this all the time. But my favorite example is, do I need to know about the knee surgery option today during an open enrollment when I'm trying to pick my deductible and know what my new premium is? Or is my surgery in 3 years? So how do you get right information, right time, and support in your engagement strategy? Let's see what our response rate is. So it looks like we do have a majority on this webinar. This one blows me out of the water. So 70% are using tiering and steering to guide to preferred value providers, which is great. And yeah, that one's throwing me off. Clearly, it's rendered me speechless. I'm impressed by that number. I'll ask you, Matt, are you seeing anything different across the country? I know.
Yeah, I think it's our next slide. I think
numbers.
If I click forward, I think we've got the results. Yeah, so I mean,
there you go.
Networks is the thing that we're always asking about. I mean, so we tend to do a range of network options every year. So if we don't have the particular network option you're interested in, we probably asked it in 2024 or 2023. I mean, we see relatively small shares of employers who are using what I would call more sophisticated network options rather than just providing broad access to a PPO. So, I mean, the green bars here are firms with 5,000 or plus more workers. These are, I mean, obviously larger firms who have more sophisticated network strategies often. And then the blue is 200 or plus. So even in that 5,000 plus category, we only have about a quarter that have a high performance or tier network, exactly what we were just talking about. I would say that's a relatively small percentage relative to what we just saw, with 70% saying they were doing some sort of tiering. This is obviously when you have differential cost sharing to try to encourage people to go to providers who provide better quality or lower cost care. The rest of these are sort of more, I mean, I think a more draconian, let's say, provider option is having a narrow network where you sort of drastically reduce size of your provider network in order to get your hands around cost. I mean, we get about 17% of employers who say they do, of the largest employers, who have a narrow network, which I think is relatively small. I mean, many of these employers may be offering this as an option, or as a lower cost option. But I think it does speak to the fact that many employers feel like they want to maintain broad provider networks or feel like they have to. Another thing on here is about the directly contracting with providers. I think there's a lot of interest with employers who feel like they don't have a lot of options around cost, whether they directly contract with a hospital or health system to get a better deal on prices and direct some of their enrollees to those facilities. We get 18%, so 1 in 20 of the largest firms, 1 in 5 of the largest firms are doing this sort of direct contracting. So still relatively small. That number's up significantly from the last time we asked, which was about 3 years ago. So there might be some movement happening in the market here. I mean, I think the next slide's on primary care, and then, oh, no. So let me talk about direct primary care then. I mean, I was a little surprised by the direct primary care number here, which is relatively small. So we get 8% of employers who have direct primary care. Having done these focus groups with the Alliance and others, we kind of get a sense of why employers are thinking about this, and it definitely ranges. In some places, the direct primary care is a part of the network strategy in which you're trying to sort of screen, diagnose, provide better access, and then make sure you're getting your enrollees to providers who you think will provide high value, efficient care. In other cases, it's about buying access. And when you think that you have a population in a rural area and they're not getting sufficient access to primary care, the direct primary care contract can sort of fill that in. So employers are thinking about this very differently and solving different problems. I mean, there's obviously a tremendous amount of interest in direct primary care in the last couple of years, and new rules from the budget bill on how HSAs can be used for them. So I think this might be a growth area. I wouldn't be surprised if this was a growth area. Melanie, I just said a lot of things. Do you want to react or disagree, take issue with any of that?
No issue.
Oh, sorry.
No, that's all right. Go ahead, Lynn.
Well, I was just gonna, jump in to echo what Matt said. It's that there are employers with different needs, and we saw a lot of like rural employers looking at direct primary care who were thinking about ways to provide access options versus thinking about cost changes. But yeah, Melanie, what else have you seen here?
We're seeing this as one of the newer strategies. We've been very system driven. So as employers want to help teach employees where to go or give them options, some of the direct primary care providers are effectively helping them steer, if you will, or take care of health differently and offer that benefit. We also have seen some access concerns, so in various areas, and that employers are supplementing their benefit strategy with direct primary care contracts.
I mean, that's interesting to me. I think I have a new network strategy, which is something I'm watching into 2026, and I hear better about it nationally, is about these variable copay plans in which you sort of drastically reduce your deductible or eliminate the deductible, give your enrollees sort of a app, and then you get a copay that is specific to each provider. So United Healthcare has a product that is doing this, or other insurers are developing products like this. I mean, the idea is you can offer a lower cost plan and try again to get your hands on a price by sort of directing people to these more efficient providers. I was asked about this question in the survey, and I did, and I was expecting a very low prevalence. So in my mind, sort of almost 1 in 10 was actually a big number here. I don't know if you're seeing this in Wisconsin yet, or any growth of these sort of variable copay systems as a way to think about as a network strategy.
Yeah, well, 2 different comments. We've seen tiered copays for quite some time, but I think this concept is different than the way those on this session might view it. The way that we're seeing it is actually reduced cost, reduced deductibles, or a more affordable tiering or varied copay structure to steer into the highest value providers to counter the higher deductibles, I guess. And they vary a little bit differently. So again, we had seen some tiered copays for quite some time, but this is a different concept. I just want to call that out. And I know we have a few more slides, so I'll move us on to the next one and zip it for a second on my end.
So we already talked about direct. So primary care is a place. I think there's a sufficient number of access concerns in some places. I mean, I think one thing that lots of employers are doing are thinking about ways to get people primary care through virtual options. So amongst the largest employers now have a virtual primary care option, still low levels of the direct primary care, as we discussed.
Yeah.
I mean, I think those are the big findings. I'm happy to talk about what people want to talk about or what we should be asking people about in 2026 as well.
Yeah, that's a great segue. Thanks so much for walking us through the data and some of the highlights for hot topics that have come forward to us. Let's give Matt and Lynn a virtual round of applause for sharing their insights. Thank you both so much for both conducting the focus groups and then helping us compare to national data. Thanks to everyone on the webinar that joined the polls. We appreciate it very much. So now that we talked through the data, do you mind if I ask just a few questions? And
yeah.
Perfect. So 2 things that I'll start with. When we talk about tiering and steering, we've spent some time on that or setting up different access. The purpose of that ultimately is to help guide behavior in consumerism. One other strategy that we saw implemented to tackle that was high deductible health plans and health savings accounts in the early 2000s. And I think that the traction on impacting behavior didn't quite take off as much as expected. We've still seen increased cost. And from a utilization perspective, there's really 2 outliers that throw that off. We have those that hit the deductible early on and then have 100% coverage, or those that are intimidated by the deductible and maybe don't go in. So they're not high utilizers at all. And those 2 buckets really aren't being impacted by consumerism. In the long run, do you have any insights in whether both of those strategies stay around, or do you think one wins out over the other? Do you think we keep high deductible health plans and go that route and have tierage in our traditional plans? Or do you think we're going to try something new and evolve?
Yeah, I mean, it's a good question. The HSA are kind of interesting, right? We were expecting this to put more skin in the game and you're going to make better choices to your plan. And I, for a bunch of reasons, HSAs have taken off. We now have 30% of people enrolled in an HSA qualified plan. It's up significantly this year. So we've continued to see growth in this HSA world. Yet the price of an HSA plan, while on average cheaper, grows at the same rate as plans overall. So we're not seeing sort of like bending the cost curve, as was the phrase that we like to throw around in sort of the early and mid 2000s in HSAs. I mean, there's a whole bunch of things working against you. It's hard to shop for things when you don't know the price of them. It's hard to shop for things when you don't have the administrative capacity to sort of handle it. I mean, I count any day I get my girls to sleep without pasta sauce in their hair as a win. So, I mean, managing my health plan on top of that is another thing to figure out. And transferring the sort of the burden of figuring out how to shop for care onto enrollees, especially enrollees who need services, is a challenge. And Melanie, I think you hit exactly the right thing. So much of health spending is driven by so few people. And those are the people who hit the out-of-pocket maximum, enter the HSA qualified plan, and then they've lost their sort of incentive shop. Was 1% of people are accountable for some huge percent, half of spending nationally. So I think that is exactly the challenge around these HSA plans. They're sort of making you change your behavior sort of on the low-cost services. Does the HSA take a win? I think that there are considerable interest in maintaining the robustness of HSA plans. I mean, lots of people like to use them as a tax savings vehicle, which could have benefits for you as an enrollee. Go ahead, Melanie.
No, I think you hit on it. There are benefits to both. But there truly is no silver bullet on the consumerism side. So the education and teaching employees, regardless of the strategy that is in place, is really what ultimately needs to happen. There's some evolution in how we use healthcare, how we understand benefits, and what's actually in place by employer. Shifting on to another question, I noticed in the slide on network strategies that vendor to offer specialized menopause care was specifically called out. That was notable to me because it's an outlier. It's more granular than some of the other network strategies that we've talked about today, or as an industry historically. What other specialized vendor categories are you seeing? And are there any that bubble to the top or are emerging as kind of the next steps as add-ons, if you will?
Yeah, I mean, we tend to rotate through a bunch of these sort of added benefits that employers want to offer to sort of targeted populations and provide robustness to their services where they think their provider networks can be more robust. I mean, so menopause care or women's health in general, I think was definitely a focus for lots of employers in the last year. I mean, I think another place that we've looked at this is in sort of treatment for fertility and IVF coverage, which is often covered, not reimbursed as part of the provider network, but we paid for it through an HRA. And I think there's all these sort of supplemental vendor third-party solutions or point solutions. Another place is advanced EAP, which I think is sort of growing or maybe growing amongst employers, as employers want to offer more services, especially for mental health, before you end up going into the provider network. I mean, many employers are thinking about specialized options for some conditions or treatments inside of the provider network. I mean, obviously, centers of excellence remain sort of a big part of many strategies, getting some populations for high-cost services or substance abuse, where you want to make sure that you are getting people to services and providers who deliver high-value care. So obviously, there's tons of concern about utilization, which is inappropriate amongst unless you can get to those sort of high efficiency providers.
That makes sense. So just to recap, I'm hearing infertility, mental health, substance abuse, based on the population of that specific employer, or kind of,
yep.
That makes sense. I would love to jump over to Q&A. Before we do that, Matt and Lynn, what is one key takeaway that you'd love to make sure everyone leaves with today?
Lynn, you want to kick us off?
Sure. I guess my key takeaway is that the story on GLP-1 drugs is really not yet written. And unfortunately, that means that it's something that we all just have to keep an eye on to see how we should be changing plans or what that means for employers and employees in the future. And I think it's probably a similar question about other high cost drugs as well.
I mean, for me, it's like employers have played this tough role in our system as we expect them to do so much on setting up the incentives and pushing back on healthcare prices. And that's a tough job to be a healthcare purchaser. It's also a tough job to set up your incentives in a way that you're providing something your employees can understand. They understand the choices they're giving, and they can afford the choices they can give and make the choices that will help contain costs in the health system globally. Lots of people put a lot of pressure on employers as sort of the counterweight to growing healthcare prices, and that's a tough gig. And that's why I think we see sort of on these network strategies, sort of employers are kind of all over the place nationally.
Perfect. Thank you both so much. From the Alliance perspective, our account executives, our team, myself, we're all here to support you on answering questions specific to your population and using data to support the next step in your benefit strategy. So please use us as a resource. We do have a few questions in the chat that I would like to address. And I know there were thank you to those of you that submitted questions in advance of the program. One of the questions that we got was, how are cancer treatments impacting the overall cost? And what I'd share is cancer costs and treatments have become more expensive. And I alluded to it a little bit earlier, but wanted to specifically address this question. The costs have grown significantly over time. As medicine evolves, it's not becoming less expensive. The treatments are definitely increasing. However, more importantly, we did, as an industry, take a step back on those that were getting preventive care screening. So when people were kind of staying in their home, not accessing care, that included skipping critical preventive care or early recognition kind of treatments. Encourage go back to your staff and remind them to get the preventive care treatments. What we found coming out of that was more frequency and severity. So Dr. Cotter did mention offline that the most recent data was not that this frequency had increased, which is great news. That was not the case directly out of the pandemic. However, for those that are not getting treatment, the severity does impact cost significantly. One of the questions in the chat is, what's the average percentage of folks who have zero claims? It's one of my favorites, and not
just
planted.
looked at this. I mean, I guess the Alliance, you have your own estimate. Lynn, do you remember? I think it was a quarter, isn't that right?
I think it's a little bit less than that. Yeah. It sort of depends on the population. I mean, if your population is in general younger, then we expect there to be a sort of higher percent of people without any claims, because if you're younger, healthier, less likely to go to the doctor at all. But yeah.
We do have some great graphs on the Peterson KFF Health System Tracker that look at the distribution of spending and what percentile of people are responsible for what share of spending. But to have zero claims, even that, you get a big chunk of people.
Sure. And if of interest, would those be something I could share, Matt, outside?
Yeah, absolutely.
Directly?
Yeah, we can send you a bunch of additional resources.
Perfect. What I would add here is I've heard a wide range of anecdotes on this topic. I think it's most important to understand your population. Going back to the early prevention and taking care and managing your health, I think that's the most important. If you have a high percentage of folks that have $0 in claims, but they're not managing their health, it's just waiting for that claim or that large shock claim to come forward. If it is just your population, demographics, young, healthy, taking care of themselves, are they still getting the preventive care things that are age appropriate and right for their situation? I think it's knowing the audience, knowing your numbers, but we could absolutely circle back on averages on a broader scale.
I think Blue Cross put out a brief in the last month that had this number. I can pull that up from their population, which is a lot of people.
Perfect. I know that we're coming up on the hour, so I just want to restate and rethank Matt and Lynn for joining us for this great discussion, sharing your perspectives and the data. If you'd like any additional support outside of what we shared today, please reach out to your account executive at the Alliance, or anyone within our growth team if you're not a member of the Alliance. We're happy to help you out. You can access the business development team by scanning the QR code on the screen if you have not worked with them in the past.